If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further. Today we have a guest for the show, Sheila Philcil. Sheila, thanks for doing this. Really appreciate it.
Thank you, Vic and Marcus. I'm really happy to be here.
So we have caught up over the last couple months, but for the audience, maybe give a little bit of your background. You're a social change futurist and health equity expert, but what does that mean in real life? Like, how does that manifest in your work you do day to day?
Yeah, so I was a health equity expert, I guess, before being a social change futurist. My background in change and training is in public health, as well as financial economics. So I've had a 15-year career in healthcare, solving big problems, running like complex operations, doing strategy work. And my last role was director of innovation for a health equity accelerator. And throughout my professional and personal experience, I keep running into some of the same problems in healthcare that I think are kind of ubiquitous when it comes to solving for social issues, where I think technology can play a role in solving it, but it definitely needs to be people and human first. So as a social change futurist, I am very curious, interested, and driven and thinking about how do we bridge that gap between what's possible with technology while also not losing our humanity, but actually unlocking our humanity through our shared experience and stories to really shape how we solve problems.
Yeah, excellent. And that's part of the reason I wanted to do this conversation is I think many of us got into healthcare to make a difference in people's lives, but then the day-to-day, the systems, the infrastructure, all the status quo sort of not knocks us off course, but pulls us into other things, and we maybe lose the story. I want to start in your background. You're a first-generation Haitian American, and I think you were thinking about medicine as far as being an MD and the practice of medicine, and then you had an experience in Haiti that sort of changed the course. Maybe talk through that. What happened in Haiti, and tell us about that experience and your change in direction.
Yes, I love sharing this story. Anyone who's first generation, like Caribbean or African descent, you can relate. Your path is kind of chosen for you. You're told you could either be a doctor, lawyer, engineer. My dad did give me a fourth option, which was to be a politician. And I did choose the doctor route just because I had this innate desire to help people. I grew up with a mother who was very like community oriented and altruistic and would have us watch a lot of the television programs around like missionaries and doctors in foreign parts of the world and in Africa in particular, like helping people, improve their health and well-being. So I always thought that that would be my path. And I was, pre-med all through undergrad, even, did my MCAT. And I went to Haiti in 2006, and it was definitely a life-changing experience. I went actually as a medical volunteer with a group that was doing rehab medicine because that was the domain that I thought I would be going into. And this was before the earthquake, but what they were doing was in the central part of Haiti, Port-au-Prince, were offering services to families who had children or themselves were dealing with disabilities. These could be cognitive or physical disabilities or people who'd had injuries. So they were developing prosthetic limbs, giving people wheelchairs, teaching them how to use crutches. It was a very kind of like real time on the ground, giving people like this great access to healthcare that otherwise wasn't available. While I was there doing this great work, noticed that many of the families who had traveled many long hours, days to get to this clinic were returning the items that they had been given, like the crutches and the wheelchairs and everything else. And the volunteers and myself were like quite perplexed because it was like, well, we brought all this equipment,
we're came all this
trying
way.
to help people,
Right,
came all this way, like, we're using our vacation time, all that good stuff, like what's happening. And I think the initial instinct was to think that, people were just ungrateful. But, being Haitian myself and I speak the language, I started talking to people and I began asking them questions like, what's going on? Like, why aren't you using the equipment? Why are you returning it? And what I learned from those conversations where people were telling me that, they had to cross a river and we told them that they couldn't get it wet. They lived in a shanty town where there was no wheelchair accessible ramps. They had to like crawl through very narrow crevices. So it was easier for them to crawl than to use a crutch. And of course, like for me, after hearing those stories, it became very obvious like, oh, well, clearly we did not think about your living conditions when we were designing these solutions. And it became very obvious to me right then and there that um, we're very limited, even with great technology, we're very limited in helping people if we don't truly understand their lived experience. And I think we probably had been better giving some of these people skateboards than crutches, right? Because at least they could like pick it up and keep moving. So that experience really, it was actually right after that I made a shift and decided to go into public health as I wanted to better understand the systems like poverty and access to, education and good food and healthy living situations that really lead to overall people's well-being and health.
Yeah. And so you are in Boston now. Did you start your career in Boston?
I did. So I moved to Boston to go to Boston University, where I started my degree in public health and have pretty much stayed put and have worked in various like healthcare settings in my career here.
Yeah. Okay. And so you touched on your interest in stories as a way to guide public health and health equity issues. We talked about your grandmother's story in the past, but maybe weave your grandmother's story and sort of her cancer journey with how you think about using stories to really connect with people, because I think that's something that is really valuable in empathetic healthcare and public health in any kind of care that sometimes in our technology-driven world we forget. So maybe talk about your grandmother's story and stories in general.
So my grandmother was diagnosed with stage 2 breast cancer and actually found out about it at my grandfather's funeral. My grandfather had actually died from Parkinson's, and his death was actually quite tragic. I literally watched him waste away because neither myself or my family were able to get him access to treatments and medications that were actually available at the time. And also, I was happening to work at Dana-Farber Cancer Institute, one of the best, leading health, cancer hospitals in the world, really. So by that time, had been several years into my role and really understood from the inside how cancer works. Like, how do you get diagnosis? What are the differences between a specialist like a medical oncologist versus a radiation oncologist and a surgeon? I had even helped implement a lot of projects around access in clinical trials and other things. So I knew the battle that my grandmother was up against. However, she was on Medicaid. My grandmother was at the time well into her old age, deep into her 90s, and she didn't speak English. She, lived in Haiti and came to the States, as an old woman with grown children. So I knew that her journey was going to be incredibly difficult if I had not stepped in. So I really became like the primary person negotiating with insurance, making sure I transferred her care from a local hospital in Orlando, where my family lives, to the Moffitt Cancer Center in Tampa, which is one of the best available in that part of the country. And actually, it was because of some of my connections working with cancer doctors that I asked them to connect me with these specialists at the Moffitt Cancer Center. I don't know if they would have seen her otherwise, considering that she was on Medicaid. But I definitely used every privilege and every access that I could to guide her through, she did oral chemo, had surgery and radiation, and even negotiated with the insurance to have her get rides to and from Orlando to Tampa every day for her radiation therapy on Medicaid. Because my family did not have the means to be able to support her beyond, essentially like her basic necessities. So her survival was literally dependent on her getting these treatments and completing the cycle of therapy. And again, like I had to make sure to coordinate having someone with her, making sure that there was an interpreter, speaking with the doctor, being on the phone to kind of relay her symptoms and some of the things that were going on to make sure that things were not getting lost in translation. It's one thing to be an administrator who's making decisions and policies and thinking about access from an abstract point of view. It's very different when it's someone that you love dearly.
Yeah. Yeah. And so there's a change in your career going from Dana-Farber, Director of Oncology Inpatient Operations, to then shifting to Boston Medical Center, Director of Innovation for Health Equity. Did your grandmother's story and your experience with her affect that? Or what was that transition in your career to move over to Boston Medical Center?
So it was a couple of steps that led to that, but it was actually a bit of a reckoning with my own career and my intentions in the work that I was doing that came right around the time when I was helping my mother, my grandmother, manage her cancer treatment. You'll probably remember CAR T cell therapy came out, and it was a big deal because this was a potential cure, but it's also a very, very, very expensive treatment. My responsibility was to figure out a way to essentially throttle the number of patients that were coming to our hospital for this treatment to make sure that the hospital would be able to bring on patients who had the insurance that could pay for it, essentially. And so I'm an excellent at my job. I'm a great project manager. So I helped design essentially a system where insurances were flagged as either red, meaning like those insurances would not cover it, therefore we would not see those patients. Yellow, meaning they might need some prior authorizations, and green. And what I noticed after this got implemented, I looked at the patients who were coming in to receive the treatment, and they were all white. There were no Black patients that we were treating. And it took a while, but after a while, I realized like, oh my God, I implemented a system that essentially cut people out who needed this therapy. Now, who are the people that are on the red list, right? These are their insurances like Medicaid, insurances like the one my grandmother was on. So thinking about it as someone who's fighting for my grandmother's life, and I'm making decisions that is essentially blocking people from accessing this care. And it was a serious like moral crisis for me, to the point where I had intended to write an email to the CEOs of the Dana-Farber and Brigham Women's Hospital, because I was reporting up into both of those. And I stopped to talk with my boss at the time to ask for her advice, because I was like, this is wrong. Like, we are literally implementing inequities in the way that we're doing this. And yes, I'm part of that, but I want to change it. And the advice I got was like, you could do that, but you have to think about your career. And I chose not to say anything. I chose not to send that email, and it haunted me. When I got the opportunity to transition to Boston Medical Center, my first role was actually as a director for the neurology department. So I had even more direct responsibility for the care of patients and for the environment that we were creating for providers and teams. And I just made a commitment to myself that I was going to do it differently. I was going to approach this with people first, with equity. I would say the hard things. I would do the hard things. And that's essentially what led to my evolution as transitioning then to Director of Innovation for Health Equity, because I brought that, fervor in the work that I was doing. It was noticed. In my first year at Boston Medical Center, I was awarded the BMC Leadership Award for my leadership around health equity and DEI. And I was able to have a sit-down conversation with the COO at the time and essentially pitched this role, Director of Innovation for Health Equity, and the position was created for me. So it was just building on my experiences and trying to correct some of what I had been part of in terms of designing systems that were not working for patients.
Yeah. And so talk to me about what you learned at Boston Medical Center in that role, and maybe transition to the healthcare status quo topic. Like you've talked a lot about how much money we spend and how poorly it's utilized, really, if you judge it based on outcomes. And what were your learnings trying to push innovation around health equity at Boston Medical Center, and then how can you relate that to the overall system?
Yes. So Boston Medical Center is an essential hospital, which essentially means that it's serving patients with no insurance or public insurance. Mostly that was our demographic. More than 70% of our patients were on some sort of like public insurance or lived below the federal poverty line. 30% of our patients spoke a primary language other than English, and a large proportion of our patients were Black and Brown. So the imperative was kind of built in to the work that we were doing. And Boston Medical Center was actually one of the first public hospitals in the country. So there was kind of in the legacy of this place to really serve people, and regardless of ability to pay. But obviously, when you're an administrator like myself and you're given budgets, and you have to hire doctors, and you have compensation plans, and you have to make sure that people are paid fairly, and then you have to hire, nurses and medical assistants and interpreters and social workers. Like, it takes a lot of people for healthcare to function. And it always felt like we could not keep up, like we could not get the numbers to work so that we could pay people fairly, not, stress people out to the point of burnout, which we hear about a lot, while also trying to provide the best care for our patients in a highly regulated environment with very few, like, really good innovation that's making it easier to do that. So the way that I see from that experience, I've come to understand that hospitals in particular really serve as pass-through entities. You have healthcare insurance companies that, kind of collect money to, pay for healthcare. That goes to the hospitals, but only a tiny margin is really going to support the staff and administrators. And then the rest goes to biotech, med tech, health tech. And then on that side of the ledger, you have companies that are worth billions of dollars. And in the middle, you have providers that are being increasingly squeezed to do more with less, and patients that are waiting months, if not weeks, to see the specialist that they need, hours in the emergency room, delayed diagnoses, ineffective, highly, expensive treatments. It's overall like a sick care system that doesn't really work well for the individual. It's been my experience overall.
Yeah. And so I think, just to rephrase, make sure I'm following, there's an infrastructure, a system that has grown up over 50, 60 years in the US that maybe was well-intentioned at first, but now it is sort of has a lot of momentum and is going a certain direction. And I think what you have told me offline is that system is designed for sort of this provision of care across as many people as possible, but maybe not thinking about each particular patient as an individual story. And so it's difficult to change. Is that close to what you mean? Is that kind of what you mean?
Yeah, absolutely. And I think, when healthcare first developed in this country, it was very centered around doctors, right? So, and I think when we saw kind of a shift away from that, with kind of curbing fee for service, right? Because that became one of the things we saw as a driving force behind the cost of healthcare. Doctors kept, essentially billing for a lot of things because it was a way to generate more money. We curbed a lot of that with some of these like value-based payment models and accountable care models, and, bundled payments. But so we've squeezed that down, I think, as much as we possibly can. But at the same time, we're not giving doctors and patients more tools that can really help them navigate these illnesses and treatments, because they're not really designed with the patient's lived experience at the heart of it, right? So we have a lot of innovation as it relates to specific treatments and, different drugs and therapies and devices, but we still lack real innovation as it relates to the nuts and bolts of how we care for patients, how we engage with them, how do we keep people healthy, how do we make it easier for the doctor and patient to have a really great relationship so that they understand what's happening and can, pivot and make changes, right? So I think that's really what's missing right now.
Yeah. And so coming up through this environment at Dana-Farber and Brigham Williams and then Boston Medical, you lived in the system, like you really understood the system, you understand the system. What are some specific ways we should try to rethink or reimagine how the system is designed really to maybe be more patient-centered or focus on the actual care being delivered to the patient?
Well, I think one place to really start is when we look at the kind of healthcare innovation ecosystem. We have millions of dollars that go from venture capital and other innovation kind of funders into healthcare startups. But 98% of them are failing, and some of them are failing miserably. And even some of the innovation that's coming out, again, I was one of those people that was being
Yeah, I mean,
flooded
Part
with.
T is an incredible innovation, but it may not
Yes.
be getting down to everyone. For instance, like an example of it. Yeah.
Right, exactly. It's not getting down to everyone. You're having these big investments and risks in these kind of like innovation and clinical trial pipelines, um, where most of these products are failing or not getting to some point of efficacy. So the ones that are making it across the finish line cost a lot of money. Whereas I think if we started innovation with the patient's story and their lived experience, there's many more solutions that people already have and a very deep understanding of their own lived experience with their diagnosis that can really shape some of what we're coming up with and shape the solutions so that we have more successful remedies and treatments and health technology and all the things that would really lead to a more robust and comprehensive way for taking care of patients.
Yeah. And so is that how you came across one of your new endeavors, Phicil-itate Change, is really a new framework for entrepreneurs to think about creating or developing innovations. Is that sort of where you're headed? Is Phicil-itate Change a way to approach this?
Yeah, so Phicil-itate Change is my startup, which is offering both advisory and AI solutions for healthcare innovators, really with the intention of putting patients in the center, really being very radically patient-centered. And the first product that I'm working on building is Compass Project. And Compass Project is intended to be a platform that is utilizing blockchain and AI to really help health tech entrepreneurs and innovators to accelerate their time to product market fit through directly engaging with patient stories and their data. And this platform will be able to generate very unique and deep insights so that as the product is being developed, where the features that it includes, the way that it works, even things like, do you have the appropriate language of accessibility in your product? And are you thinking about the person in terms of their whole life, like as a caregiver, not just as a patient, for example, right? So those are the kinds of things that we want to bring into that innovation space. Because what I'm seeing as kind of like a broad failure is we're applying technology innovation principles into healthcare, and healthcare is a very human space. So we need to have a different approach for social innovation that is people-centered. It's nice to have like a Facebook or a Tesla where, they can come up with these fancy products that we didn't know we needed, right? And now we're walking around with pretty much a computer in our pocket, right? But when it comes to our healthcare, that is a very deep and personal experience. And someone who's lived with diabetes, for example, for 15 years, they're the expert in how to manage and treat their diabetes. And we have to tap into that knowledge by honoring and centering innovation around patient stories.
Okay, so let's dig into that a little bit more. Say there's a new startup in Cambridge, two founders at a coffee shop trying to figure out a way to bring a new innovation to diabetes. You introduced me to this new term, at least new to me, social listening, combining that with product development. How does that work? What does it actually mean to the founders? How do you engage with them? What is social listening for the audience? And then how does that really help the founders make faster progress?
So social listening, or you might even think of it as patient engagement, is essentially talking to people about their experience, right? And learning from them what works and what doesn't. And today, what that looks like might be, surveys or focus groups, right? To collect people's lived experiences. So with your example of the two founders in the coffee shop, they might put out a survey on their website or talk to people in their network who have diabetes and say, hey, I'm building this app, for example. These are the features it's going to have, and this is what it's intended to do. Would you use it in yes or no type of thing, right?
Is it,
The
sorry to interrupt,
limitation.
is it similar to customer discovery, where we would talk in startup planning, you talk about customer discovery, like trying to learn about your customer? Is that a similar concept?
It is a very similar concept to customer discovery, and it builds on it in the sense that with with the current model, it's very limited sampling in terms of the number of people that you're able to survey, and also like when you're collecting static data, you're losing the context without the story. So let's say I want to develop this app for a newly diagnosed diabetes patient, right? So you might be able to ask 100 patients, when were you diagnosed, and what was your A1C when you found out that when you had diabetes, for example. But it's very different if I'm diagnosed with diabetes because I show up to my doctor's appointments every year and my doctor's noticing my A1C levels are going up, versus someone who was walking to work, their eyes got blurry and they hit the pavement and they showed up in the emergency room and found out they had diabetes. That is two very different types of diagnoses, right? So we really want to deeply understand the context and the story of people's experience so that we can really tailor the interventions around their experience, right? So that we're not guessing. Because what often happens is we might, come up with our best guess of what we think the product might need to function, test it with patients or people, and then we kind of iterate from there. But what often happens, or what I've witnessed this, is that either you run out of money or the testing is still not robust enough to give you enough information about what really works for this particular segment or population.
Yeah, and I think sometimes as you're surveying 5, 10, 15 potential patients or customers, you end up losing a lot of the context, all the depth of the story, the empathy side of it, all that qualitative stuff gets lost because it doesn't fit neatly in the survey. And then when you roll it up to a summary, you get the static quantitative things, but you lose a lot of the power of the story.
Exactly. That is exactly what's happening.
So how does your tool help with this?
So Compass Project would first start with some sort of like quiz or assessment to help the startup founder or innovator understand where they are in their process. So I do have a framework and questions that you can fill out that help you understand where you are and where's the next step for you in terms of developing your product. And then it's really making sure that you have a very clear objective and clear like problem statement, like what problem are you solving and what is the feature that you're really testing or bringing to the market. Then Compass would be able to go out and source patients to essentially like ask questions about their experience directly related to the problem that you're trying to solve. And the beauty about this is it's also intended to do this at scale to collect stories and data. So we're not talking about sampling a couple dozen patients. We're talking about a couple hundred or thousands, right? So that you get really deep data and that we have deeply representative data. Right. So we're not just looking at things like, do you have representation in terms of gender or race, but also language, ethnicity, or even like if you were firstborn versus left-handed versus right-handed. Those kinds of like nuanced information we don't really get at because our sample sizes aren't big enough, right? And once we've checked a few boxes, we think we've talked to enough people, but you can really dig deeper when you collect many more stories and data from patients. Then using the power of AI, we can take those stories in that data and roll it up into very deep insights where you have the information, but it's contextualized and you kind of like go deeper into the layers of this particular profile or customer avatar, if you'd like to call it, so that you have a deep understanding of their lived experience and how they may interact with your product or solution that you're developing.
Yeah, that's pretty interesting. And there's benefits all around. Like there's benefits to the founders because you're bringing additional users, additional patients to bear to make their customer discovery, their product evolution better. But then even if that startup fails, Compass is maintaining this database of all of these stories. So if another diabetic startup in Florida came up, is it right that they could also tap into these same stories? So you're starting to build up I don't know, a database of people that could be helped.
Yes. And one thing I'll correct about that is Compass will not own the data. Patients own the data. This is why blockchain is going to be central into how this technology is built. I'm a firm believer in data sovereignty. I do think that that's where the disruption needs to happen in healthcare, because we do a lot of data hoarding right now. And to your point, that is very valuable that we collect a lot of this information, but it ends up dying with the founder or being hoarded when these institutions. Whereas this is going to be designed so that the patients own their data and they can consent on who accesses it and they're compensated for it.
Yeah.
So that they are, again, the center of the innovation.
Yeah, great. So that's a good correction. So each patient can consent to kind of opt in to all the startups around diabetes, or only some of them, or whatever they choose to do. And there's a compensation mechanism around that.
Yes. And becomes easier to scale because once you've asked the patients these questions or collected some of the baseline information, you don't need to repeat the same questions over and over again. There might be nuances and then updates, right? But they essentially now have there's like very valuable real-time data that can be accessible to innovators.
Yeah, interesting. So when did you start this, and is it working now? Is it in process? Have any startups used it? What's it like now?
So I'm very much early stage. This is month 5
Right.
being a full-time entrepreneur. I'm in the process right now building the team to develop the tool. I already have interest in terms of beta testing, and I'm actually starting by working with a few health tech startups as kind of like my first iteration of kind of collecting their stories as well in terms of what their experience is with their customer discovery and product market fit, so that we're adapting our solution to their needs. So a little bit of practicing what we preach.
Yeah.
But my goal is to have a prototype by March of this year and a fully developed MVP by August. And I'm looking for beta testers, would love to talk to entrepreneurs and folks that are, connected with patients and associations or social organizations as well.
Okay. I think I understand how blockchain can help with the data sovereignty and the patients owning their data in an encrypted way that they can opt in or not. How are you leveraging AI for it?
So the AI helps us with generating the insights. As you know, AI is essentially, mining data, and large language models are more ubiquitous now and accessible. So when you talk about collecting stories, it's a lot of unstructured data, right? Actually, one of my first jobs while in my career, while I was doing my public health, was working as part of a grant-funded Center for Innovation and Social Work, where we were interviewing patients living with HIV and AIDS because we were trying to solve the problem of how do you keep patients, particularly those from marginalized communities, engaged in care and taking the medications. And what we did was we actually went and talked to patients who had HIV and specifically talked to those who were managing it well, transcribed the interview, went back and like highlighted to find the patterns, and then turned that into a curriculum where we were able to teach community-based organizations how to integrate peers into their care models. And it was very, very, very effective. But now what would take probably dozens of people to do.
Yeah, right.
Yeah, you can do that with AI. So that's going to really allow us to unlock the insights from the stories and the data from patients.
Okay, excellent. Well, it's exciting stuff. Talk to me about what your hopes are for the future. Where do you see this going?
I would really love to create a robust platform where every early stage entrepreneur or innovator in the healthcare space is able to access this and create solutions that are really designed around patients. But also, I think what would be really great for me is to work with startups and get at that early stage and be able to say, hey, this is a good idea, but you need to change this feature, or this is actually not a good idea at all. Don't invest in this. Like, don't build this. It's not going to help anybody. Because I do think we have a lot of technology out there that that just is wasteful and in some cases harmful to patients because they're really not intended to do to reach what, the real problem at the root cause. So I would really like to see less waste in this space so that all of these startups are much more successful because they're grounded in the patient experience.
Yeah, I think that's a great, incredible vision. I mean, I think it's pretty widely accepted that maybe 1 out of 10, maybe less startups are successful. And that means that there's a lot of time, a lot of capital, a lot of technology, a lot of effort that is wasted. And
Yes.
I would take the view that people are well-intentioned, but they don't really know where their product doesn't fit with what the customers and patients need. They don't know if they should pivot in this direction or this direction. And if your tool could really help them get those insights more quickly, make their course corrections more effectively, maybe we could get to 5 out of 10. And that would be a huge uplift in sort of the number of innovations, the number of solutions that can really help patients out there.
Absolutely. And we desperately need it for people like my grandmother, right? Or even going back to the story of the work that I was doing in Haiti. If there had been an initial work to just go into the community, observe people's lived experience, understand their barriers, we would not have shipped all these expensive and heavy equipment. We would have been able to come in and use the resources effectively, right? So that there would not be waste. And healthcare is one of the areas where we really need, when we waste, it is actually harm because that is dollars and resources that is not going towards helping people that really need it.
Yeah. Excellent. Well, maybe give a hand up. Where should people go to a website to learn more about Compass and facilitate change, and so they can get involved, maybe be a patient or have a startup to contribute? Where should they go to learn more?
Yeah, so you can go to my website. It's Phicil-itate. So it's a play on my last name, Phicil-itate Change.
Yeah, we'll put a link in the show notes so they get the spelling right. So facilitate change.
Yes, and there you'll be able to find all the information about Compass Project, to connect with me, to sign up to get more information. I'm really interested in talking to patients as well as entrepreneurs as we're building this product. So looking for folks that want to beta test with us, and people who have ideas in terms of how to shape the technology as well. Would love to talk to people. And you can also find me on LinkedIn, Sheila Philcil, and love to connect with people and share and learn from others as well.
Great. Sheila, thanks for sharing this. I'm super excited about the Compass Project. I'm going to be sending some of my companies to get involved, and I'd love to see it mature and get out there and help more patients and more entrepreneurs. Good.
Thank you. I'm really excited for the future.
Thanks for doing this. Really appreciate it.